For the next panel, we gather 4 real masterminds and 5 if you actually include our great moderator, Mihaela. And I'm going to just give a brief introduction because I know that I'm late and I apologize with all of you. I know that some of you also come from countries where when this is an awful time in the morning or middle of the night, as you prefer. So let me start with the introduction. I'm going to start with Ray NG, who's a long-time friend of SingularityNET Foundation and has recently co-founded an AI and blockchain startup called Care Protocol together with his brother Roger. Ray is a physician by day and a technology entrepreneur, coder, and blockchain developer by night. He's a medical doctor with board certification and licensure in Canada and the US. Ray now runs the COVID-19 assessment site in Vancouver, Canada. Next is Dr. Maurice Ramirez. Maurice has an amazing biography that I would love to read it all, but unfortunately we don't have time. He was the first person to receive the Lifetime Achievement Award in disaster medicine for his contribution to healthcare security and disaster medical response worldwide. He's board certified in 9 specialties. He's a former senior physician and federal medical officer, emergency room doctor, disaster medicine specialist, and bioterrorism expert with clinical and field response experience spanning over 2 decades. Dr. Ramirez serves as an emeritus medical director of the High Alert Institute team that is currently reviewing the whole of the scientific literature to identify possible treatment for COVID-19. Next, Mr. Aga Manhao is the co-founder and managing partner of Future Health and health tech angel investment group based in Singapore. He's also the CEO of Futurist Solution, an advisory firm focused on technology innovation in healthcare, including technologies such as blockchain, artificial intelligence, and machine learning. Chris Ware is a co-founder of Ikigai and founder of Verida. He has more than 20 years devoted to developing software solutions. His deep technical knowledge of the centralized database and blockchain has provided a technical foundation for the Ikigai Global Health. And to moderate this panel, we have the outstanding Dr. Mihaela Ulieru. She's a technology alchemist, and she's an innovator at the edge of the impossible. At the peak of her academic career, she founded the Impact Institute of Digital Economy, aiming at policy reforms for the adoption of the latest digital technologies in all areas of society and sectors of the economy. And over to you guys. Thank you so much for waiting.
Thank you. Thank you so much for this introduction, and thank you panelists for being here with us. First of all, I just want to say that I have the scenario about the vaccine documentary, so please convey to Susan. I mean, it's just mind-blowing. I watched over the weekend, the Totally Under Control. It was really, I wish I would say inspiring, but it was more, concerning. So let's see what's coming. I really trust Ben's 90%, and I want to believe in it. However, in this part of, the summit, I heard words like lockdown, masks, and let me remind you, ladies and gentlemen, that the topic of our panel is sovereign identity, sovereign data, and sovereign health. So the only thing which goes with the topic would be herd immunity, because it's kind of there. Then I would feel free. So let's see how we unbundle all this. A few salient points about the topic. Well, sovereign health, I think, and I will take them in the reverse order. Sovereign health, it's clear, yes, it is my health. It is a personal matter. But hey, is it? Because during a pandemic, it becomes a public matter, and it becomes a concern in the sense that it's a civic responsibility for the health of the others as well. Number 2, sovereign data. Well, how much do you need to know about me to keep me healthy? I hope my co-panelists are going to answer that, it's minimal, or that I can keep it private. And when it comes to sovereign identity, well, and the work which you are going to present here, illustrious panelists, I'm thinking about that you are building the tricorder. I cannot wait to have it on my phone and have it with me. So even without Dr. McCoy, to be able to self-diagnose and be guided towards better health, even now, when I cannot see maybe except on Zoom. one of you who are specialized in medicine. So the question is, and with the tricorder, I just remember sometimes they encounter certain aliens. They had no idea who they are, but they were keeping them healthy. So the question is, do you really need my identity to keep me healthy? A lot of questions. The thing which I want to underline here is that my panelists are taking medicine to the next level. From its paternalistic, one-size-fits-none, to quote Maurice, outdated approach to the personalized approach. And they are building the tricorder. But what does it take to implement it? And how can we use it? And when will we have it? All these questions are coming. So I will start with asking Ray, who is a luminary doctor. When I spoke to Ray, and I heard his talk in the previous summit, I truly couldn't believe that he is a medical doctor. I mean, this is not my concept of a medical doctor. It's just mind-blowing how illuminated he is and his approach. So I would like to ask you, Ray, how is the open health movement that you are spearheading changing the paradigm? And how do you enable this via your health OS, to paraphrase our summit paradigm? Thank you.
Yeah, thanks, Mihaela. That was a fantastic introduction. I think my reputation precedes me here. It's a great segue. I do want to, give props to Dr. Eva Lee, how she was talking about, and it's a great segue into testing as the cornerstone and overcoming misinformation. And even on her talks about vaccines and sort of that clinical application of science. I think for this panel here, what's interesting is that extends to the clinical applications of technology as it applies to medicine. And so, that conversation on sort of a heterogeneous approach to vaccines and distributions, I think that also applies to technology. We don't want a single electronic medical record to rule them all. We don't want a single approach or schema or framework to sort of be this top-down approach. And so I think, I remember a story from my late mentor, Clay Christensen, and I used to audit his lectures, and he would tell me that this sort of innovator's dilemma, the sustaining trajectory of innovation, where all of the actors currently in the space have through no fault of their own, a bit of a myopic view and disregard for what he'd call technological enablers of our generation. So whether that be the semiconductor and the microprocessor or TCP, and what we all know in this room collectively, and what I believe in is the decentralized web, or Web3, sort of built upon blockchain. And so this sort of concept of an open health movement, it kind of reminds me of how I've been practicing medicine as a family physician in a COVID testing site in today and the years past, and how I see things moving forward. And I think a lot of the panelists here, folks in this event in general at large as well, how it used to be was you'd bring a problem to a solution farm. So in computing, you bring a problem to a mainframe computer. In telecommunications, you'd bring your message to a telegraph center. So that's all evolved. But in healthcare, it was ossified, and we would bring our disease to a hospital after the fact, after you're sick. And the approach there, as Mihaela appropriately discussed, was a very paternalistic view, is that as a physician, we tell you what to do. And unfortunately, what I think we've in our industry now come to realize is what's called a therapeutic relationship. It's a two-way street. It's an open conversation. And this concept of openness in an open health movement is essentially challenges that my colleagues and I here have been working on for years. Open borders. How can you actually treat and provide therapeutic relationships to folks globally? So cross-border payments. How can you actually provide incentives and reimbursements across the globe? And so the concept that came to us was we actually can't build this in a silo. In fact, it all evolved out of inspirations from the open source community. So as we all know, when the pandemic hit, what was sort of a sliver of innovation in healthcare suddenly cracked wide open. So what was a top-down approach, which is suppliers of technology, big data, big vendors, big healthcare, pushing upon us solutions and technology, inverted, in which it became a bottom-up approach. And so our partners and our mentors ended up contributing to the solution. So we became the solution, all the way from our partners basically drop shipping N95 masks to our physicians at their homes, to our open source communities, some of which you're going to hear on this panel, creating open source frameworks and panels of technological stacks that essentially have been reinvented. And so what came out of all of that is what we call the Health OS. It's essentially an operating system for physicians, kind of like the iOS for the iPhone. And it's just a place for physicians and patients to plug into what some of the folks will talk about at this event called the Ikigai Network. It's basically a place to download dApps, decentralized apps, for technologies. Basically, physicians can take the technology they need, and we've built it for you. So there's things in there like a physician AI interface. Yeah.
So, and that's exactly the transition which I want to make now, because there is the second part. So you started with the health. So now let's go and move to the data. Chris, as a sovereign data warrior, that's how I see you. You are creating the tech foundation for this thing, this open health movement, which Ray is talking about. So my question is, when will we have it? What are the challenges that you are encountering? What are the most important things that you want to share about your work in this regard? And you work together with Ray. So, of course, it can be a dialogue between you. That is allowed on my panel.
Excellent. Thank you, Mihaela. So, yeah, really, really good question. So I guess I'll probably highlight that we've actually come a really long way. The Ikigai Network is, I guess, a new project, but there's been, a significant amount of work up to this point to actually build technology and demonstrate technology that can provide this decentralized data foundation that the Ikigai Network will be built upon. So that's included things like how do we get decentralized identity and leverage public blockchain and encryption keys to give people their own data? How do we enable developers to build dApps where the individual owns their own data and it's encrypted and the developers can't even see that information? And obviously, one of the key pieces is with what we've developed is an Ikigai Vault, a data vault, and that will be a mobile phone app that sits on your phone and allows you to not only access all your data, but provide consent for your data to move around between different dApps and different systems, and provide that true, I guess, vision of people owning and controlling their own health records, and doing that in a way that is interoperable with decentralized permissions. It's performant, so it's fast, and solving a lot of very interesting technical problems. So we've actually come a real long way to having that ready, and we're actually running that on a test net at the moment. So it's really exciting times from that perspective. I think the challenge, though, that exists here is much like with DeFi, which has created a new way of developing apps for the finance sector with smart contracts and thinking more collaboratively and in terms of ecosystems. We have the same thing now with this new era of data and decentralized data, where there's these new toolbox. There's this really fantastic tools that we have, but it's new for developers. So there's an education piece there in terms of how to utilize this technology, how to build dApps, what are the common design patterns that work here? How do we simplify this for developers and onboard them to take advantage of this sort of next evolution of how software can be developed for the health sector? So that's a really exciting challenge. And at the same time, we're, I guess, cultivating developers of dApps. Healthcare is a $4 trillion industry in the US. It's just dominated by large enterprise players, data silos. So another challenge that we have there is how to take this technology, continue to innovate, but build the trust and the tools to enable those enterprises to unlock their data, give them the incentive, give them the rewards to unlock that data and start to participate in this new open health movement. Because fundamentally, for this open health vision to be effective and to work long term, we need a combination of the innovators that are disrupting the incumbents by developing decentralized apps and innovating in that space. But we also need to bring across the incumbents that are wanting to merge into this space and see the problems that we're able to solve and help them do that in a meaningful way.
Yes, and hopefully this will help us when the next one hits, because, I'm really concerned now when I heard Ben saying this was a dress rehearsal. It's like, wow. So, Maurice, it's time for you to come to the rescue as an awardee of the Disaster Medicine Medal, because we not only are in the middle of this disaster medicine situation, but also the response was a disaster, as we all know. So please let us know, is there hope when the next one will hit, that we've learned something from this dress rehearsal? And what? So please.
Well, Mihaela, the area of disaster medicine is the delivery of healthcare in a disaster. And you have to understand that a disaster is any time that your needs exceed your immediate resources. Now, unlike the rest of this panel, I haven't written a Stitcher code since the mid-1980s, so I'm at a distinct disadvantage compared to Chris and Ray. I rely on people like them, much younger than I am, to take care of that technology end. However, even back in my day, if the resources on the network or the needs on the network exceeded the resources, you had a network crash. This is something that we understand, whether it's in technology or it's in healthcare. We had a resource crash with this pandemic, without question. This disease came fast, it came hard, and it exceeded local resources on such a regular basis that it cascaded across the globe. Now, we can argue all day long about what political events compounded that issue, but the reality is that we are still far behind that curve. But it also, as Ray pointed out, and as Chris pointed out, this brings us a great opportunity. Following 9/11, myself, other colleagues, we founded and created disaster medicine. We codified it, we characterized it, and ultimately we certified it and created a certification board. Now is the time for AI-assisted precision medicine. It's a return, if you will, to a system of medicine that is centuries old. Traditional Chinese medicine, hieroglyphs in Egypt, all describe the concept of individualized care that is about the individual patient, sovereign to that patient, with regard and respect simultaneously, an and statement in my old days of programming, to the responsibilities to this greater society, to your neighbors, to protection. And
Absolutely.
that whole concept is where precision medicine is needed. Now, the problem of precision medicine in the modern era is the volume of data. And masks, and you and I spoke of masks at one point, and vaccine today, as of today's announcement, are key examples of this. If you had asked me in December, when mask mandates were beginning in China, long before they made the press in the United States, if a mask was going to be useful, as an expert who studied this on a number of occasions, including SARS, I would have told you, probably not, but our first edict from the Greek, first do no harm. Primum non nocere, first do no harm. It can't hurt, might help, as one of my mentors used to say. By March, we had learned that it did help, but it didn't help on the virus side. We didn't believe at that point. But what it did is it empowered the individual patient. It restored a sense of something I can do. It restored sovereignty. It gave them a power, very much like Chris's vault does, gave them power over their healthcare. I can wear a mask. I can do something about this virus. I don't have a vaccine. I can wash my hands, but now I can wear a mask. And more importantly, I can see if you're wearing a mask. It gave resilience. All right.
Yes.
By June, we had learned that, wait a minute, this mask actually blunted peaks. It did it in Australia. One of the first reports came out of Chris's backyard. It turned out when the Chinese finally released their data that it actually had blunted it in China. And then by then we also knew that it was blunting it in Europe. But we didn't understand how. These were, in many cases, what we considered subpar masks for healthcare purposes. They allowed size microns much larger than the virus to pass through the mask. In an engineering standpoint, it made no sense. The science was evolving so quickly that our messaging was getting behind, to the point of the last group, the last topic and last panel, was that the messaging was now getting behind the science. And the messaging was changing so quickly that people were beginning to lose confidence. Well, now come September, we actually have the engineering understanding of how a 5-layer cloth mask prevents spread of a 7-micron virus.
At last.
It's not by filtration, at last, but it took 10 months. In that 10 months, people lost confidence, and many lives. There were many people who refused to wear their mask because, well, the textbook says it doesn't work. In the United States, OSHA says it doesn't work. Yeah, hazmat says it doesn't work. Well, in fact, it did, just not the way that the N95 respirator worked, not the way that a PAPR worked, but it still worked. And this is the problem of disaster medicine. But
yes.
AI precision medicine has the opportunity now to help us do something that they haven't had the capacity to do since the mid-1980s. And that is keep up with the data, not just the data coming in an anonymized fashion from reviewing many thousands of patients worth of records in almost real time, so that I know what's working on the other side of the planet as I'm addressing patients here, but also that capacity to scan and adjudicate, and that's an important word, adjudicate the scientific literature, so that when, as a healthcare professional, Ray Ang asks a question about something new that he's seen, he gets not 12 million Google search responses or 68,000 Google Scholar responses. He gets a list of possible treatments and explanations.
Maurice, thank you so much. I will come back to you. This is amazing. You are the fire hose, which I know. Thank you so much. It's amazing, and it's clear to me that disaster medicine. I mean, it's when science is evolving with the disaster. Yes, so it's co-evolving. We do not know. It's just like the 9/11 attack. I mean, we do not know. Is it an attack? What happened? Is it an accident? And then it evolves, and it's like this. Yeah. Well, let's hope that technology can help us there. So, Aga, most of the people who have been affected and lost their lives are the elderly. And you are working on communities of health that involve elderly care. I learned from Maurice that the Disney Epcot Center was initially supposed to be a community of health, which I had no idea. So I do not know what your communities of health look like, but I know that you are using high tech, like Internet of Things, in order to anticipate from their guide if they're going to fall, also to anticipate from the way in which they move if they are infected with COVID-19 before they are tested or before this is really known. So tell me, how do you use technology? What is the status quo in Asia where you are? Is it adopted faster? Of course, I'm sure you will share also the lessons regarding COVID-19. There's so much I want to hear from you. Maybe I asked you already 10 questions. Please let me know more about your work.
Thanks, Mihaela. I think the challenge is, especially here in Asia, is about technology will solve all the problems. And I think the one thing that Singapore learned fairly early on was the adoption of wearing masks and, in want of a better word, contact tracing. So we did very, very well early on. And then there was an outbreak of the virus in migrant workers' dormitories, which really increase the number of cases. However, the one thing that's been consistent since February, March of this year was the compulsory wearing of masks and contact tracing. So you could not go anywhere without having to check into every single venue. So sometimes it's quite annoying. The government made it wasn't compulsory, but you had to use a tracking device. It was a simple app that everyone had to use. But because we have had 2 incidences of the Ministry of Health being hacked, there was a very big reluctance of the population to actually use this government app. And I think it comes back to a lot of things that we're talking about. Who owns our data, right? And this is the big thing. So what they did was there was a fallback. It was QR codes to be able to go into everything, but it was compulsory. You could not go into anyone without using QR code. And as of a couple of weeks ago, we're now going back to the contact tracing as our numbers have hit 0 cases for many, many weeks now. And that it is now almost being forced upon that we need to use this contact tracing app so that everyone can manage where they are. And that I think here in Singapore is that we're doing some amazing jobs in terms of clinical trials for vaccines and all of that. But the real simple stuff is really the low tech stuff that we're using, such as apps to basically track and monitor and everything else. And I think that has been exciting. I also believe, though, that as we move beyond this, and I've had discussions around, our migrant workers here in Singapore, we have probably 200,000-300,000 migrant workers. They live in dormitories together, very close proximities and everything else. And the reality is that we can't keep them locked down if there is a breakout. So the conversation has been, how do we use technology to monitor and trace and allow them to go about their everyday lives? And I think part of that conversation is, well, what if they had their own data on their own apps? So things like if they do catch coronavirus, how do we identify it very quickly? How do we triage it very quickly without having to lock them down again or lock a large population? So although technology has been fantastic, it's some of that low-tech stuff that's actually working here in Singapore.
Thank you.
Yeah.
Oh, okay, no, sorry, I just said the feeling you are done. So
no, I was just going to say, so for the elderly here, it's the same. It would come back to how do we manage that high-risk population. And unfortunately, especially here in Singapore, where we do have so many elderly, it's our numbers have been quite low. So we've only had 28 deaths here in a population of 5.5 million. But the majority have been in the elderly. The great thing that we have done is being able to contain that and work with the communities to make sure that they are triaged the quickest and get them the help the quickest. In Singapore, we have outstanding healthcare and we have outstanding physicians to be able to do that. And I think they've managed to circumvent, a bigger outbreak in the elderly community, which has been fantastic.
Thank you. Fantastic, really, yes. And, I don't want to downplay technology, first of all, because I am a technologist, but also because I truly believe it can help us. And, for me, of course, simulation modeling and all these advances which Ben showed us, that practically you can see how it evolves and we can learn so much from the science, but also you need the technology to encapsulate that science, to bring it to us in our homes in order to be able to be prepared. My question is now to Ray and Chris, and I know maybe it's an unfair question, but I have big hopes from technology. Do you think that we can reconcile sovereignty and this need for isolation, masks, contact tracing, in which we may need to reveal our identity or our data? Is there a way in which to reconcile this through technology? Are you using that?
Yeah, I'll have a first stab at that. I think that's a really good question because I think there's a perception out there that the only way that this can happen is by giving up some of your identity and giving up your data. Whether that's scanning a QR code or whether it's filling in Australia, I have a lot of venues where you just put your name and phone number on a piece of paper at the door, very, very basic. Or whether it's a centralized system in Singapore, where all your data is going to the government and they can track exactly every, venue that you've entered. There's obviously some privacy concerns there, if you're a journalist and you're having meetings with people and things like that. So I think at the moment, there's a bit of a perception that it has to be done that way. The reality is that using decentralized identity, using distributed, data vaults that are attached to healthcare, in terms of you owning your own healthcare information, using things like zero-knowledge proofs, there is actually the ability with decentralized identity and blockchain to actually have a separation between, can I contact someone without knowing them who they are? Can I request information from someone so they can prove to me digitally that they haven't got COVID because they've been tested recently, and do that without necessarily knowing who they are, but seeing that person standing in front of me? There's the ability to have that separation between, identity and data and health information. But it's an area that I think, because it is quite new, there's obviously not necessarily the trust or the understanding of the capabilities that are there. And I think that understanding probably doesn't exist in the wider community or at levels of government that are making the decisions around these particular problems. So for me as a technologist, I sort of get a bit frustrated looking at these things and going, look, there's some really great solutions that can be applied here, but it's going to take time. You mentioned, Mihaela, about how we're still kind of learning as this pandemic is unfolding. And I think that, the different technologies that we have available to us are still kind of evolving while this pandemic is evolving. But I'm hopeful that, in the coming months, these conversations will continue to evolve and there'll be a deeper understanding of what's possible.
Yes. So Ray, tell me, when the real one strikes, to paraphrase Ben, this is a dress rehearsal. How will open health help? Will it help? Did we learn something from this? So how do you see it? And of course, not only for the next pandemic, for everyday health, but of course, yes, in emergency.
I happen to agree with Ben there. Some late night Zoom conversations with Dr. Ben Gortzo and really hitting it off on some of these topics. I mean, the last question that you asked that Chris just addressed and this one actually kind of mold together. I guess I'll try to answer it with my physician hat on as opposed to the tech hat. What we've seen in our profession is there's a bit of a codependency here between physicians and you name it, blank, software vendor, the government, with their handouts, policy for clinical trials. And so, when we say that the solutions which have been most effective are the low tech solutions, I do happen to agree with that. But it's tech nonetheless, so I kind of see this as a grassroots movement in which these solutions are being delivered by entrepreneurs, they're being delivered by technologists, they're being delivered by healthcare workers and frontline workers. And to your point about, what is our role, our civic responsibility to be wearing masks or to be sharing our data for clinical trials? I think what we're seeing at the end of the day, we're all just trying to get along here, whether we're in America, I'm in Canada here, and on Saturday, they just announced a social ban. And, we believe to be, a very free nation, but a social ban was basically no household visits whatsoever, unless you're a family. They called it the Safe Six, you and 5 other relatives, essentially. And so I think what we're noticing sort of across the interwebs and so on and so forth is this sense of a loss of free will or a loss of freedom of speech, all of those types of things. And so there's this whole discrepancy now on face mask wearing and so on and so forth. And I think what Dr. Ramirez was saying was sort of this oath that we take as a physician, the Hippocratic Oath, which is to first do no harm. And so if we were to think things like from a technological standpoint, do we truly have anonymity? Or should we just kind of throw that on the back burner and just contribute our data for the greater good, right? And as we know from the Bitcoin protocol, there's sort of some pseudo anonymity there, not full-fledged as we know, but that's being worked on. And so I would say I'm quite hopeful that from an open health movement, when you have enough folks putting their joint efforts towards developing a new healthcare economy, a new healthcare technological stack, the way that I see all the folks in this call and all the folks in this community and on this event, they're essentially reinventing the infrastructure that healthcare was traditionally being serviced on. And so that is the encryption of data, which the technology's been here for quite a long time now. Even very simple low-tech solutions like telemedicine. I mean, that's been around for a long time, and traditional vendors did not implement, I mean, VoIP, right? The VoIP type technologies has been around for like 17 years. And the large software vendors did not roll that out until a pandemic. So it's interesting to think, are we going to rely on a lot of these sort of, big vendors to provide the solutions, or are we going to do it ourselves? And so I think taking control, and what we see that now, closing about a dozen plus clinics in the lower Vancouver area, and using very low tech but tech solutions to send out messaging to patients to say, don't come in, we're closed. Let's do this over televideo. Everyone's just trying to do their part. And I do think that the open health movement, which is basically open data sharing and open source development, will be that grassroots reinvention of the infrastructure of healthcare. And you have folks that are essentially delivering it now in real time. And this is the time that it's needed. And as I mentioned earlier, that opportunity now, the door swung wide open. So anybody that is a technologist or an entrepreneur or a visionary blockchain enthusiast watching or tuning into any of these calls, now is sort of their call to action to join in and contribute.
And Maurice, so I'm not sure if you answered, but maybe you did answer, in the sense, what I understood was that next time we are gonna again co-evolve when it happens. But do you think that technology, open health, will help us cope better next time? Give us hope.
Yes.
But also be realistic.
Yes, it will. And in large part, it's people like Aga and Chris and Ray and the other people who are in the audience of this call, who are going to bring those technologies to bear. And then it's going to fall to the policy end people like myself, who are going to have to weigh in and apply pressure as necessary to the political people who stand in Ray and Chris's way to say, guys, from a health security standpoint, we blew it last time. 69-page plan that was written in 2004, updated in 2007, updated in 2009. I was there for those three, updated in 2017 after I retired out, and totally ignored. Now, I know that every person on this call has been challenged to write code very quickly overnight and could write a 69-page plan in a week. So even if they had claimed to lose the National Pandemic Response Plan for the United States, it was only 69 pages long. They could have written one in a week. They could have called people like myself. We would have had it for them in 2 or 3 days. We missed it, no question.
Yes.
We got behind, we couldn't keep up with the data. And now we have people who are bringing us the data and bringing us data in a usable form, which is the most important part, because too much data is just as much a disaster as too little. And having that data in usable form, where we can adjust it based on, again, that anonymized group of patients, where I don't have to know all 40,000 Chinese patients in Wuhan. All I need to know is that by putting them on their bellies and head down by 10 degrees, that I reduced death rates by 62%. 62%. Unfortunately, we didn't learn that until May. And we should have known it in January. Think about that. 62% of the deaths from January.
My question was, will we know better next time?
Yes, because next time around, there won't be this siloing of data. There will be the tools There already are the tools. I happen to know because I watched Chris demonstrate a few of them a few months ago. There are already the tools to collect that data in safe spaces.
Fantastic.
And to share
Thank you.
and to respect that sovereignty.
Indeed. So Marcelo, are there any questions from the audience before I ask my panelists to leave us with their learnings or takeaways?
Yeah, they're not questions directly from the audience. Also, because I think it's getting quite late in Europe, so people are following the event more passively. But
and probably the US audience is following the elections more than us.
Perhaps. But I mean, the video are going to stay online, so they will have plenty of time to watch it later. But I do actually have a question for the panel, and then I'll let you do your closing remarks. So yeah. So the first part of our event was dedicated to the decentralized governance, and I was wondering if in healthcare we're ever going to reach a point in which it's possible to have some sort of democratic participation in the decision-making process. I mean, it seems that the decentralized decision-making regarding this pandemic has failed under many aspects. The World Health Organization is heavily politicized, and one of the points of Biden's new program is to rejoin and reinvest in the World Health Organization. So I was wondering whether we can find a compromise between heavily centralized decision-making and a more decentralized way.
Fantastic question. Who wants to jump?
Yeah,
I'll jump. I have the health because I have the health policy history. If you don't mind,
and then Ray, of course, each of you. This can be the takeaway also. So yes, go ahead.
When it comes to this more democratized, decentralized decision making, that gets to the very core of, as Ray pointed out, what we seek to do as healthcare providers is to empower our patients to be given the best menu, if you will, of treatment options, of lifestyle change options, and then allow them, empower them, join with them to make the best possible decision that fits them as an individual. That for us is what patient sovereignty is all about in the clinical world. And the ability to do that in a disaster is completely dependent on having enough information and enough adjudicated information to give people not just a menu of choices, but some concept of risk and benefit. What's going to work, what's most likely to work, and what are you giving up if you choose to do something less than the platinum standard? And then what works best for me may not work best for Mihaela in the exact same circumstance because my life is different from hers. But what the ideal here is, the democratization is that I get to make my choice, and Ray as my provider respects it equally to the choice that Mihaela makes, to the choice that Chris makes.
And I would add to this, also a matter of perspective, which I think, and the weight is here on your shoulders, Ray, as a medical doctor, that, in educating the public and the eventual patients, it's, to look at a mask not as an infringement on your sovereignty, but rather as empowerment. This is, during this panel, is first time when I heard this take on it. And it is indeed, yes, I can do something. It gives me some idea about what the others are doing and if I should stay more away from them or not. So indeed, it's also a matter of perspective. Please, Ray, you were you wanted to jump.
No, absolutely. You guys both nailed it there. In terms of education, that's key. And in terms of decentralized governance and self-governance, I mean, I haven't seen a better example than in our first open source community called ASCO19. It was a COVID-19 community. And the decision-making there was what to build. So, I mean, 3 to 4 days a week, I'm seeing, cumulatively hundreds of patients a day for COVID testing, clinical assessment for COVID pneumonia, listening for bilateral decreased respiratory air movement. And the question there is, well, a large percentage, Vancouver is a melting pot of all ethnicities. And when we needed to deliver after visit summaries and educational materials in Hindi, in German, in Korean, in Chinese, none of that existed. And the technology's been around for a long time. And so when a technology needs to be built out, we all know about GitHub issues. Let's put a little issue there and let's vote on what gets built next. And so in the Bitcoin world, we know what are called BIPs, Bitcoin improvement proposals, or Ethereum improvement proposals. And so how does that work? It's a vote. And what happens if people don't agree? You might get a contentious hard fork and end up with multiple forms of Bitcoin. But in fact, that leads to anti-fragility of the system, and technologies end up getting built. That's far superior to what we've experienced in healthcare, where there's no vote and there are no hard forks, but there's also no innovation and no development and no evolution. And so, I guess as sort of my sign off here on this sort of self-governance and decentralized governance, what I would say is that you guys were talking about people watching the election right now. They're discussing handouts right now, these bailouts, right? They're going to do a check that they're going to send out to all Americans. Now, what I would say in the healthcare space is that there's no bailouts coming. Yes. Those seeking a bailout are probably up for a rude awakening. And those checks that are going to be delivered also are not sufficient for what's about to come. I mean, we see for us in Canada, we're a bit delayed. We're always delayed compared to the US, but we're entering our second wave now. And so whether it's seeking bailouts from vendors or big healthcare or governance, I mean, they're not going to come and rescue you. So I think what I would say, and we're familiar with this terminology in the cryptocurrency space, which is not your keys, not your coins. What I would say here is not your keys, not your medical records, not your keys, not your data. So take control of your health and be the solution that you seek. That's all I would say.
Thank you. I love it. Aga.
I totally agree. I think the technology now exists to decentralize everything. You and I spoke the other day about our vision of having a place where people could, use other people's data or enhance their data through AI and everything else. That exists. I also love in terms of we can now collaborate to build upon what is already there in a more meaningful way, rather than having one silo that says this is our way and this is how it's done. I don't think that exists if we want to progress technology as quickly as we need to in the current day. So I think what Chris is developing, allowing developers to use code that is already pre-made that can be applied to current application makes sense. To use physicians to have their experience put onto the same platform so people can share makes sense. To have patients share their data and their patient history so that we can develop better solutions makes sense. So it is there. I think that the call out now is what Ray said, people watching, listening, let's do this. We all believe it can happen. So, collectively, we need to create a movement that proves that this technology and the way of collaborating is the way forward for global health.
Thank you. And Chris, you have the last word before me.
Thank you. Look, I think there's a clear message here, and I probably just want to reinforce it. I think that message of collaboration, that message of it's not going to be top down. It's going to be those at the grassroots level, the physicians that make a decision to choose something that's decentralized rather than go with the technology incumbent. The technology that we have with Ikigai Network, this ability to have your own data, enable that exists today. We're rolling this out. There's a test net. It's really up to the innovators, the people that are watching this today. You guys and girls are the future of this space, and it's up to you to sort of take this, learn about it, create new business models, start to innovate. As I mentioned earlier, the US healthcare sector alone is $4 trillion per annum. There's a huge wealth of opportunity to disrupt the incumbents who are effectively hodling their legacy centralized data silos. You know, they're holding on to these legacy systems. And the potential that we have for personalized healthcare, unlocking data for AI, for clinical trials, or for improving on those personalized solutions, the ability to aggregate this data in anonymous ways and analyze it to create new medicines or treatment plans, particularly in a pandemic. The ability for physicians to have AI that runs over all of their notes and helps them learn about the services they're providing and provide better clinical outcomes to their patients. There is so much untapped opportunity here once we start to unlock this data and open it up more broadly across the healthcare sector. So I encourage everyone who's listening today to who is a developer and is interested in this space to dive in, have a play, see what you can build, and jump off that cliff, because it's people like you that we need to make this a reality.
Fantastic. So, to conclude our panel, there is no better time for humanity to realize how interdependent we are than during a pandemic. I heard today about cross-border apps in Europe, which to me is like a no-brainer. But of course, there was again a political issue, so it was approved. My health. So this is kind of, a realization. Like, for me, we are all responsible for each other's health. My health depends on your health. If you are healthy or infected, my health depends on that. So it is time to come together. So I think I can see this, this virus, an opportunity to humanize humanity and to remind us that we are in it together, to put our data and resources together. And in this open health environment, there is a lot of hope. So thank you so much for giving us this hope through technology. And let's keep building this amazing Ikigai network and health OS to be prepared when the true one strikes, Ben. Thank you.